Hi, good afternoon, ladies and gentlemen. My name's Gabriel Fitzpatrick. I work as a registrar in public health in the Health Protection Surveillance Centre, but I also work as chairman of Doctors Without Borders in the Dublin, in the Irish branch. So back in August and the start of September of this year, I was out working as a doctor in the case management centre and as an epidemiologist in the community with MSF, Doctors Without Borders. So I don't have a lot of slides. This is the only picture I have, but I'll talk around it. And I'll just tell you about what was happening out there while I was in Kowloon. So this is, we're in the middle of the jungle. This picture has been taken in the middle of the jungle in eastern Sierra Leone. Several months before that, that was all jungle, but MSF cleared it and we created this case management centre, which now has 100 beds. And this is the area we're working in, basically. So Sierra Leone, 6 million people. The average person lives till 45 years of age, and the government spends about $200 a year per person on healthcare. This facility had 300 staff, and it's important always to remember that the 300 staff here were in this MSF facility were local people, people from Sierra Leone. It wasn't Europeans or Americans or Asians flying in to save the day. It's the local people doing the hard work on the ground here. Basically, just because there was lots of things mentioned today, but in terms of our triage and admission, part of my job, I would triage and admit hundreds of Ebola patients during my time there. And it's just always remember to just recall how weak this virus is outside the body. Because when I triaged patients, invariably, almost all patients who came in were able to walk in. They had fever, they had headache, they had aching joints and some muscle pain. That's what they had, the vast majority. I would triage them. I would stand 3 meters away from them in a scrub top and a pair of Wellingtons. That was my personal protective equipment. No, I'm not belittling. I'm just letting you know what we were doing. But the key thing to my safety was staying 3 meters from the patient. You won't get Ebola if you stay 3 meters from a patient or stay 3 meters from any fluid that patient has produced. So it's what we call personal protective distance. It's more important. It's as important or even more important than personal protective equipment. Stay 3 meters from an Ebola patient, you won't get Ebola. Only one time in all those admissions did I actually, during triage, put a mask and a pair of goggles on and the patient was vomiting explosively. That was the only time. So I left triage, put goggles and a mask on, and then went back in. That was the only time. Every other triage was in a just normal scrub suit. It's important to remember, this is we call these Ebola treatment centres. They're not Ebola treatment centres, they're Ebola case management centres. What we're doing here is not a medical intervention, it's a frontline emergency public health intervention. We're taking patients out of the community, asking them to stay in this centre, giving them some minimal medical intervention, which is broad-spectrum antibiotic, antimalarial treatment, oral rehydration, and some IV hydration. That's all they're getting. The real benefit is we're taking infected people out of the community and stopping them infecting their family and community members. So it's a frontline public health intervention, what's happening in West Africa at the moment. The suffering inside these centres is, I've worked with MSF in different places during famines, during cholera outbreaks, but I've never seen suffering this bad anywhere before. When you're in the high-risk zone, dressed up in PPE, you're seeing terrible things, because I may have admitted a family, a mother and all her children yesterday or a couple of days ago, and then I go in and you see like most of the mother's children have died, and to see that mother in that state after that happening, it's an incredibly difficult situation there for staff and for the patients who are in the centre most of all. Incredible suffering. You have brothers and sisters coming into the centre. Slowly, most of them die, because 60 to 70% of our admissions to this centre have died. So it's difficult, it's very difficult. And then obviously pregnant women were mentioned. Seeing a pregnant woman who a week ago was in the prime of her life in the 3rd trimester, you know, the picture of health by any other description than seeing her being admitted to an Ebola treatment centre, and invariably, because she's heavily pregnant, she dies. So very distressing imagery. What I would say is, and the other thing in these centres is dealing with dead bodies, having to deal with dead bodies. That's dead bodies here. They're stripped down, they're sprayed in 0.5% chlorine, they're double bagged in large white plastic bags, and then you take a black permanent marker and you write their name and date of birth, if you have a date of birth, and an MSFID number, and then you take them to the back of the centre, load them on a pickup truck, and they're taken to the burial site. So it's a very difficult place to work in. What I would say is that we've seen the figures, over 4,000 dead, almost 5,000 dead, almost 14,000 either confirmed, suspected or probable. But we're missing the bigger picture in what this is doing to the wider health system in West Africa. Because although those numbers are, are very large and very sad, there are a far greater unknown number of cases of people dying from normal medical conditions that we know how to treat that are not being treated. If somebody turns up with a fever in Kylune to the local health centre, the community care worker there, the community health worker, is not going to treat them. It's going to send them away because that community healthcare worker has seen his or her colleagues die from Ebola. So when they see somebody come in with a fever, most typically it's malaria, because malaria is endemic in this area. They're going to turn them away, and that person has a fever. They can't access malaria tablets. What's going to happen? One of the largest obstetric units in eastern Sierra Leone was in Bo, and that's where complicated obstetric cases were sent. It was shut down, and there's no replacement because with birth, as you know, a lot of fluids are produced. You cannot get staff to walk in there and treat these patients or help these patients when there are Ebola deaths occurring in the community. So it's extremely sad to see what's happening the normal health service in this part of the world. One of the saddest things I would say about working out there was admitting healthcare workers who I worked with one day, having to admit them to the facility the next day. Because I'm just finishing off a paper at the moment, it looks at various variables, but I was looking through the line list for some descriptive epidemiology, and 31 of our patients to this centre were healthcare workers. So 31, most of them dead. So when you're dealing with, you've got your camaraderie with your healthcare workers, and then all of a sudden you see one of them get infected with a temperature, the fear in their eyes, then them being admitted to the same centre, your heart goes out to that person, and unfortunately it can spread fear within the centre itself, because people are beginning to worry if healthcare workers are getting infected, potentially it's spreading beyond the high risk zone. Unfortunately, when I was there in August and the beginning of September, I could see the situation was deteriorating. More and more cases were turning up to this centre. Now, as a public health doctor in Ireland, if we have a measles case that isn't being taken care of, we get worked up. Because I'd be worried if somebody's got measles and they're going about the community and their contacts haven't been vaccinated within an appropriate period. But if you're here and you're turning away Ebola patients who just from clinically from looking at them, you highly suspect that they have Ebola, and then you have to tell them, sorry, there's no space, you have to go home. And telling them to do that, because you're sending them home to their families and their community, they're going to spread this disease. Ebola loves that intimate environment in West Africa where families are together in small houses, and there is lots of transmission occurring there. It's just by the very nature of a small hut. If you put 7 or 8 people into that, you can imagine there will be a lot of exposure to bodily fluids. So sending people back into those communities, into that situation is, it's heartbreaking for anybody. But I mentioned, this is what we see. We see the community, these case management centres being presented as, where all the suffering is occurring. But the toughest job in West Africa at the moment are the outreach teams, so the medical epidemiologists, the doctors and nurses who are going out into the community looking for cases and investigating clusters and taking cases, suspect probable cases, back to these centres, because you're going into the community, you're finding cases and you have to separate families in the community. That's a dangerous job, and it's very distressing, because you will usually, you know, like I can remember various cases of young mothers having to be separated from their families, and you know, the family completely breaking down, you know, causing turmoil, the village becoming very agitated, and you know, you cannot guarantee safety in that environment, because it's very dangerous. But separating families in the community and bringing back infected cases to the case management centre was very, very tough. The last thing I would say is MSF. Now I'm going to plug MSF, obviously, because I work there as helping out. One NGO has been taking the brunt of this outbreak, and that's quite unbelievable. Over half the cases have been dealt with by MSF. So that's pretty difficult to comprehend, that one NGO is taking the brunt of the work in this outbreak, and that needs to change dramatically. And it was disappointing while I was there in August and September, seeing the situation deteriorate, but unfortunately the response of the world in different larger organizations and countries wasn't adequate. So we as a general global community have failed to do the basic things that were required to stop this outbreak before it ever had the chance of spreading. That is simply isolating cases, taking cases from the community into the centres, following up contacts, and promoting reliable information into the community. We failed at numerous junctures along this outbreak to do that effectively, because we know it works. It's worked since the 1970s with all other outbreaks of viral hemorrhagic fever. It would work here, but unfortunately it didn't happen. But not to end on a disappointing note, there's great work being done out there. There's people doing extraordinarily brave things. The staff from all over the world, but mostly the staff from the three countries affected, Sierra Leone, Liberia and Guinea, they're doing most of the work to get this outbreak under control. Thank you.